is the ears and their level. Is there any lateral flexion of the neck, any rotation of the neck? You can come through the acromion processes and have a look at the level of the shoulders. From there, you can have a look at the elbows and the carry angle of the elbows, the arms, any internal and external rotation. From there, we can come down to the ASIS. Joey, is it okay if I palpate the area of your body? Have a look at their level. Is there any excess tiltage, any rotation of the pelvis? From there we come to the hips, any internal and external rotation, coxovara, coxovulgar, angle of torsion. From there we come to the knees. Is there knock knee? Are the knees more distributed outwards? We can come to the inferior parts of the patella and have a look at their levels if we want. From there we can also come down to the arches of the feet and have a look how the patient's actually standing. And then to the big toes here, just have a look at how they're actually in the relaxed position. Is it up, is it down, are they curved? We can also just have a little raise here, chain reaction, back down. Now posteriorly, Joey, turn around for me please. So posteriorly, the line reference goes through the head and down through the body, cutting it in half again. So this time, if we can see the mandible, again, is the head rotated. Look at the level of ease as well. From there, we can come straight down to the spine, we can draw a line, and we can palpate in Joey as well. So we're looking to see if there's any scoliosis occurring at all. From there, we come to the scapula, the inferior angles of the scapula. Is there any wing occurring? How far are they from the spine? And then from there, we come to iliac crest, level of L4. And then from there we can palpate around and come straight down to the PSIS right here and have a look at their levels. And then from there we can come down to the Grach-Cantor, superior portion of the Grach-Cantor. Have a look at their level again. And then from there we can just come down again to the feet, have a look how they're situated. Can we see the lateral 3 toes on each side? Is it external rotated, is it internal rotated? From there, we go to lateral view. Joey, can you please turn? So now the line of gravity goes through the external auditory meatus, through the glenohumeral joint, through the hip joint, it crosses through the femur, anterior to the knee joint, anterior to the lateral malleolus. So now we're looking at basically how the patient's standing in space, where their weight is distributed. And we can come, is there any forward head carriage, excelluris at the cervical spine? Is there any kyphosis at the thoracic spine? Is there any excess or is there any hypolordosis at the lumbar spine? Is there anterior-pelvic tilt? Is there a posterior-pelvic tilt? From there we can come straight to the knee. Again, is there hyperextension occurring at the knee? And then again, look at the feet and the weight distribution throughout the body. Joey, could you please move your foot? So first we've got the heel strike, and then as the foot comes down and the condylator comes just off the ground, we've got foot flat, and as it comes across, we've got mid stance, then we've got heel off and toe off, and then initial swing, mid swing, and then terminal swing. And Joe, keep on walking now. And what we're looking for during gait is the Trendelenburg sign, so which indicates the weak hip abductors or excess forward flexion of the trunk or forward bending as the patient's walking. Through the steps of range of motion, it might make the injury worse. Is it okay if I use my hands to assess the joint?
Yes.
If at any time you feel uncomfortable, let me know, alright? So first, what we'll do is try and bring your feet towards yourself up. That's good. Back down. Now just this foot for me, please. How does that feel?
That's good.
It's good. Now I want you to try and bring your feet down towards the ground. Good. Back to normal. And just the good side for now. How does that feel?
That's good.
Alright. So that was plantar flexion, the first one, dorsiflexion. Now we're going to do supination. So Joey, I want you to bring your feet in towards your body. Good. Now back to normal. And just to this side, bring it in towards your body. Good. How'd that feel?
That's fine.
Now out, away from your body, please. Back to normal. So the pronation. And again, enjoy. How's that one feel?
That's fine.
Now for the toes, so all I want you to do is just try and bring your toes towards yourself as much as you can. Back to normal. Just got the big toe. I want you to do it again. Good. How does that feel?
Fine.
And now just try and claw your toes together as far as you can down towards the ground. Back to normal. And now just got the big toe. Do it again. Back How that one feel? So, Joey, I want you to copy me. So, look at my feet. So, I want you to try. I want you to don't let me move you. So I'm push up against your foot. So go for it. 1, 2, 3, 4, 5. Any pain or discomfort?
No.
And then from here, I'm going to move your foot out. And I want you to stop me from moving your foot out.
Okay.
So go. 1, 2, 3, 4, 5. Supination. First one, plantar flexion. Then I want to move your foot in this way. And again, I want you to stop me if you can. Go for it. 1, 2, 3, 4, 5. So that one was pronation. And then from there, Joey again. So bring the foot in a little bit of neutral position. So now I'm going to push down. Joey, so push back up. So stop me from moving you. Yep. 1, 2, 3, 4, 5. And to check the integrity of the Achilles tendon to see if it's ruptured or not. Joey, do I have permission to go through this test with you?
Yes.
Okay, could make your injury worse. If you feel uncomfortable any time, let me know, we can stop.
Yes.
So obviously before the test, through palpation, we can also work out if there is a missing Achilles tendon or some sort of palpable gap. So for the test, we find the widest girth of the gastrocnemius and give it a good squeeze. Now this is a negative test. If the ankle did not plantar flex, indicates a positive test. Through testing. So Joey, I want you to close your eyes. Now I want to get this cotton bud and I want to just have you on your sternum, okay? Can you feel that?
Yes.
One more time. Can you feel that?
Yeah.
Remember that feeling, okay? Now what I'm going to do is I'll turn you over. For me, put it on your tummy. Okay. So from here we're going to the tibial nerve and the sural branch, the middle sural-cutaneous branch. So, Joey, let me know if you can feel this, and let me know if they feel any difference, okay?
Okay.
So,
Yep. Yep.
does that feel similar?
Yes. Yep. 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 Yep.
Does that feel similar?
Yes, I do.
Okay. So that was the sensory component of the peripheral nerve, of the tibial and sural branch. It's posterior part of the leg, goes laterally. And now we're going to the motor component of the tibial nerve, which is simply plantar flexion. So I'm checking the integrity and the strength of the muscles that the nerve innervates. So Joey, I'm going to push down. I want you to stop me from moving you. Good. 1, 2, 3, 4, 5. Any pain, discomfort?
No.
What we're looking for here really is the integrity of the tibial nerve, the motor component. So all I do is just simply have the foot in a nice gentle grasp, look at the Achilles tendon, and with the hammer I just give one good hit. There. So there was a little bit of plantar flexion there, which tests the anterior neural structures, the dura mater, the L2, L4 disc space specifically as well. So we have the patient flex the neck a little bit. Yeah. So I stabilize the hip. It is extended. I simply grab the leg and I bring it backwards. So this is the first step. Joey, is there any pain or discomfort?
No.
And from here we simply just flex the knee as well, which further stretches the fascia and the muscles in the anterior compartment. Joey, any pain or discomfort?
Just feel the stretch.
Just a stretch.
Yep.
So this indicates a negative finding. Positive test is sharp shooting pain or pain that the patient recognises.